binary logistic regression estimated the crude and adjusted odds ratio. And that was the interpretation rule, as you can see. So we did, after carrying out the study, we found out that 106 showed adequate participation, and 168 and low participation. And those are the percentages, as you can see on the board. So the supportive practices that I already talked about, those are the supportive practices. And you can see the percentages, that is, for discussion, there were many, 41, compared to accompaniment, the practical support. So men would do verbal support rather than the physical support for this, for the screening. They would either discuss, encourage women, but for the practical support, you can see it was 21, and also for the household support, that practical support isn't there. For the social demographic and household characteristic, we now started examining these social demographic characteristics and household characteristics in regards to participation. And you can see the dominant category for the respondent age, it was 30 to 39. Partners' age was the ones who dominated there. That 5 to 44 for education, most of people in Tharaka-Nithi, they have secondary education. Most are farmers, and they earn 10 to 19,000, and they make decision jointly. These are the results of the chi-square, and you can see adequate participation increased with age. 18 to 29, wako na 22. Kienda pale 50, they earned 50%. Maybe the older men, they feel, because of the years of union, they feel that now this woman is part of me, and I need to take care of her. Also the same with education. You can see adequate participation increased with education. Same for joint, sorry, but it's the same. For the income, it was the same. Those who earned more were able to participate, to show that adequate participation. And years with the partner, those who earned more years with the partner still showed the same. For the joint decision, it was most of them make decision jointly. Now I took those variables, the variables. We wanted to find, so we first performed the univariate logistic examination to examine the crude association between each socio-demographic factor and adequate male participation. And you can see on the board the results, the respondent age, partner's age, education, joint decision making were all significant. You can see the p-value, they were all significant. However, now this crude association, this was a crude association, and because each variable was analyzed separately, without accounting for influence of the other. So we had now to take the same variables to a multivariable binary logistic regression, where we entered these variables into the model to determine which factors independently predicted with adequate participation after adjusting for potential confounders. Wanted to see, after adjusting now for the potential confounders, which are these factors. You may find that maybe an educated person is earning a lot of money, but does it mean he's adequately participating? Also, the one with the age is, does it mean that he's adequately participating because of, so we wanted to find out which is this adequate, independent factor, and adjusting for the confounding factors. And this was the result. You can see we are only left with, yes, education, that shown the college and university education was 3 more times. Those who earned this college and university education, they were 3 more times to participate. Those who earned higher income, they were 4 more times. You can see, like for the income 10 to 19, they were 2 times more to participate. And for those who earned 20,000, were earning 20,000 and above, they were 4 more times to adequately participate. And also joint household decision making was also a factor. Sorry, okay, thank you. You can see the respondent age, it was no longer a factor. It was the p-value, you can see. So the discussion, our findings showed that adequate male participation in their partner cervical cancer screening was low, with only 38% of men demonstrating adequate participation. The practical support, such as accompanying partners to health facilities and providing transport, was less common. For those factors that we have found that they were significant, the higher education attainment was associated with greater male participation, and this may be because educated men have better knowledge of cervical cancer, communication, they communicate more effectively with their partners, and are better able to navigate available health services. Health income was the same. Men with higher incomes were more likely to afford transport and take time off to meet the costs associated with accessing screening services. Also, joint household decision making was also positively associated with participation, because couples who make this health decision together are more likely to support cervical cancer screening while respecting the women's autonomy. However, age and duration of union were no longer statistical significant, as I said. So the recommendation is we need to prioritize men with lower education and lower income. You can see those who have higher income, they are able to go even without this health education. But now, you see, we need to focus. Who are we supposed to focus? We need to focus with these men who have lower education, lower income. Also, we need to include sessions of respective partner communication. And as we can see, we need to emphasize on that, on joint decision making. Also, we need to provide clear service information, where to screen and where to go. Because most of them, they didn't know where they are supposed to go and get that service. We have also community health promoters. We need to bring them in so that they can help us address the household level barriers. The conclusion I'm through. So only 38.7 adequate male participation. According to university education, higher income and joint healthcare decision making remain. They were the ones that remained independently associated after adjustment. The policy implication is male targeted cervical cancer education should be tailored to men's socio-demographic realities. We need to go out there and see what are the realities or what are the characteristics that should promote supportive couple communication without reducing the women's autonomy. The women should come in. We should remember that we need to respect them, their decision. We need to bring them. So let's, as we give that health education to men, let us also emphasize that they need to respect their women decision. Thank you.
Thank you, Ngugi, for the good presentation on cervical cancer screening. We know cervical cancer is killing our women, and we are here to do what? Advance what? What is our theme? Advancing. Tumesahau theme of our conference. Equitable what? And resilient reproductive health systems through innovation, leadership, and evidence-based nursing. So without further ado, we'll have Margaret and the team from MTRH to present something on, was it on banditry?
So good morning, everybody. Good morning. As they are putting up the presentation, we are really honored to be here today and do our presentations. I'm Margaret Mungai, Deputy Director Nursing at Moi Teaching and Referral Hospital, and I'm also the chairperson for the Wound Continence and Enterostomal Therapy NNAK chapter. So we really want to appreciate all the members who have come. So today we are talking about something different, banditry insecurity in the North Rift, Kenya, the untold stories of pregnant women and their unborn. This is a case study done by 4 of us, and we are simply saying that despite pregnancy being a physiological process, it has considerable effects on the overall well-being. There is presence of associated health conditions which have been talked about, diabetes, cardiac disease, preeclampsia and eclampsia, among others. However, there is a dearth of information regarding issues women are going through in the places where we have a lot of insecurity and banditry. So this case study is simply just to try and bring our attention to what these mothers are going through. So maybe for a start, we should appreciate that there is a lot of women in the same areas that we are having these problems. Looking at Lodwar to Kainuk is around 166 kilometers, and then Kainuk to Eldoret is around 195 kilometers, and basically Lodwar to Eldoret is more than 350 kilometers. But we are finding these women coming to the institution. We see that despite the infrastructure being good, the insecurity is so much. Even to go to the water, to go to the school, sometimes you have to be escorted. So you can try to imagine what are these women going through in their pregnancies despite other conditions. So we just did a case study describing the experience and outcome. A mother has actually been admitted to the acute surgical care unit and had an inpatient stay, had a delivery, and the postpartum care. She was involved in a banditry attack. She was taking her son to school in Lodwar, but they were attacked there and she was shot. So basically this is where we did the follow-up of the mother. That is our hospital, and that you can see from this side, Moi Teaching and Referral Hospital. That is the female surgical ward, and that is our Riley Mother and Baby Hospital, where the mother had to be taken for antenatal and postnatal care eventually. So she was 38 years, gravida 3, and she was 25 weeks. She came with a wound on the right gluteal region after the referral. That was on 11th of February 2023. She was done an explorative laparotomy in February, 11th February, and we found a very big hematoma and laceration at the sigmoid colon, meaning that we had to create a colostomy, and then there was no exit wound. So this bullet was still lodged, and maybe just to say it's still lodged up to today, because it actually went to the around the hip joint, and then it was difficult to remove. But she's up and well and doing her work. And then she had a lot of anxiety because of the issue of the incident. First of all, the family, she had other children, the surgery, the pregnancy, and now that she had to deal with a colostomy. Chronologically, the care provided, it was first of all wound care, where there was a big wound around 3 centimeters, 7 centimeters, and then we did the debridement, and then we did the negative pressure wound therapy. And moving on, the wound care continued, and by the 5th day, we can see there is progress in the wound, the reduction in the exudate, and the reduction in the size of the wound. And we could see there is better granulation tissues around the wound and the peri-wound area. And then we did a second cycle of the negative pressure wound therapy. And moving on, by the 7th day, we could, after the second VAC, we could see the wound is much better, around 1 centimeter both ways. the depth and the width. And eventually when she was discharged home, the wound really healed. And we could see that this went in line with what is recommended, that there should be a lot of reduction or improvement in wound care within around 14 to 21 days. Now, there was also, before she became better, there was some surgical site infection, and I want to believe this is a problem we are grappling in our hospitals. And we did silver foam dressing, which had a good response, because silver is a good antimicrobial for wound management. So that is the mother, pregnant, tummy, there is surgical site infection, she has a colostomy, but with the counseling and all support we had, she actually did very well. For the ostomy care, we were just doing the counseling and supporting with the colostomy bags, and she had to learn to go and do it at home, so she could continue being at home with her colostomy. So we are happy that regardless the distance, prompt referral system helped us. Because you can imagine this mother all the way from there, if she was not referred promptly, then it would have been very distressing for her and the unborn. There was good progress and advance in the pregnancy, where she was actually transferred into the antenatal ward, as I've showed in the Ready Mother and Baby Hospital within MTRH. And then she had to go home to go and take care of the pregnancy, and then she can come back. She was readmitted in May, and we did an elective cesarean section, and later on we did a colostomy reversal. She has a healthy baby girl who really went well postnatally, and they are doing well at home. So what are we saying? Is that you can look at the referral system. Why did they have to bypass Kapenguria, Kitale, so that they come to Eldoret? Maybe there could be issues about the human resource for health or even their capacity, because these are patients they should have managed better out there. However, we realize and accept that modern wound care interventions improved the outcome of the patient. Negative pressure wound therapy extracts the exudate. It stimulates local blood flow in the wound, reduces the bacterial colonization, reduces edema, promotes cell mitosis and even regeneration, proliferation of reparative granulation tissue, and contracts the wound as it is sucking with under vacuum, it contracts the wound to heal. We had alluded earlier, foam dressings with silver absorb exudate and they are bactericidal in promoting health. Ostomy care health education and psychological support improved these patients' outcome and coping. And then the issue of ostomy supplies availability. I don't know where you're working, whether it is easy to get the ostomies or it is not easy. But for us, even at MTRH, sometimes we have erratic supply of the colostomy bags. But we realized that the patient, there was enhanced acceptance, there was reduction of stigma, and then there was better quality of life because she was able to go back home and continue her chores. Again, the multidisciplinary approach to care is more effective and cost effective, whereby as wound care nurses, we say always treat the whole patient and not only concentrating on the hole in the patient. Regardless of the distance, prompt referral systems actually helps and saved her life. Then there is the issue of comprehensive medical cover eases patient financial burden, because at that time we had the Linda Mama. The patient was able to go home well without having to pay anything. So in short, why am I presenting this case study today? Is because we want to say, despite the lack of much limelight, banditry and insecurity is undermining pregnant women's outcomes and their quality of life. We may be talking so much about the common conditions they are going through, but they are the same mother with these conditions in those environments. And at the same time, on top of that, they are going through whatever they are going through, including other things that we didn't mention in this case study. So there is need for emergency preparedness and response contributes to better outcomes in pregnant women and their unborn babies. So I think as we do all we are doing, there is need to focus on issues of emergency preparedness. And then the multidisciplinary health teams are key in maternal and neonatal outcomes. And modern wound care is something to focus on. And that is what we are calling upon all of you wherever you are. Focus on wound care because we have a lot of wounds with the other conditions on the rise, diabetes, trauma, and everything. And then there is also need to, the issue of multidisciplinary care promotes comfort, decency, and the negative pressure wound therapy also helps, as we had alluded, containing the exudate and lessening the number of exposure, or even changing those dressing. So if you adopt this modality in care, you can even make your own care much better. So we are calling upon all of you to actually focus on that. Lastly, there is need to improve the county lower level health facilities, emergency and specialized care provision. As I've said, why did we have to come all the way from Lodwar to Eldoret? They have done better in other areas. And there is need for communities, county and national governments to address banditry and insecurity for better maternal, fetal and neonatal outcomes. And because as we are used to presenting in places whereby your 10 minutes are done, the screen goes off. I don't want my screen to go off. I am done. In case of anything, just to me or that to me. Thank you very much.
Thank you, Margaret, for the good presentation. Next on stage is Cynthia. And your presentation has really touched me. I didn't know banditry wanga in affect what it is. It has really touched me. Seeing a pregnant woman, gunshot wound, it has really touched me. I don't know kama wengine wamesikia hivyo. Yes. And it really goes down to us looking at how our referral systems. The mother coming all the way from Lodwar, we have Trans Nzoia, which is we have Kitara Referral Hospital, we have West Pokot, we have I think it is Kapenguria Referral Hospital, coming all the way to Eldoret. This calls upon our leadership. We don't know whether it is the counties or it is us as the nurses to make the changes. Imagine a mother traveling all that distance without any assistance from the nearby facilities. It means our health systems, and we are talking of strengthening our health systems. There is a problem with our health systems, and we have a chance as nurses to ensure that we make the changes. Tunamwanga, if you are not invited to the table, you just take yourself there. Next year we are having general elections. We want to have more nurses joining the political space. Because it is us who understands where it pinches most. You are a nurse working in that facility. You just watch a mother suffering. Maybe you don't have even the basic things. And those who are in offices, they don't understand. So it is us nurses. Let us not shy from politics. Because it is the political decisions that shape our health systems. You will get an ECD teacher as your CEC in your county. You'll get some very fine people in those offices, but somebody told us, there's a politician who told us, now we will get you from the wards. I'm looking at votes, so we want the people who can mobilize for us votes. It's not about your qualification. You know, you are looking like you to have an nurse as a CEC. So tukaambiwa, nyinyi mko tu kwa wards. You are not active in the community, and I'm looking for somebody who is a community mobilizer. And for us nurses, we are at the last mile. Look at the nurse, even in the remotest dispensary, you have nurses. So in terms of influence, as nurses, we have influence even in the communities. Because even in the remotest parts of this country, you get a nurse. So it is a wake-up call for us as nurses to see open. We have Margaret as from MTRH, we have others, and we can fit in those positions. Ama tuwezi. Mimi nimekuwa nikiona hivyo. Kama at least I know if you are a nurse in that place and unakumbuka the way you used to serve a baby somewhere, I think if you get somebody telling you that we don't have this, at least utaweza kuelewa like another person. Sindio? We are the wearer of the shoes. We know where it pitches most. So let us not shy away from those positions. Useme hatutuwezi. If you are given that chief officer's position, usiogope. And tusiende tena, kuna wengine wanachukua hizo position, then wanasahau kabisa that they were nurses. Unashindwa, these were nurses who were working in the but sasa venye yako watu wanashindwa, labda hata afadhali tu mngeendelea tu kukaa na huyo mwalimu wa ICD akiwa your chief officer than the nurse. So let us make positive changes tukiwa, because tunaelewa zaidi. Thank you. Karibu Cynthia.
Good morning. I'm Fabrice Mideva Cynthia from Vihiga County. I'll be presenting on improving adolescent uptake of FP services through provider training on youth-friendly health services at Kegondi Health Center, Sabate Sub-County, Vihiga County. So background information, teen pregnancy remains a significant public health challenge in Kenya, leading to increased maternal and neonatal morbidity, school dropouts, and poverty, causing reduced socioeconomic opportunities for young people. Despite interventions, adolescents continue to experience unintended pregnancies, unmet FP needs, and limited access to youth-friendly services. So stigma, fear of judgment, inadequate privacy and confidentiality, limited adolescent-specific counseling are major barriers at Kegondi Health Center. So problem statement, records demonstrated persistently. The study was a provider training. Providers were trained how to handle the youth. So I'm comparing before the training and after the training. So records demonstrated low attendance for youth-friendly services prior to provider training. You can see in 2018, we had 56, that is the whole year. 2019, we had 36 youths. 2020, we had 52. So low utilization of adolescent FP services at baseline indicated that improving service availability alone was insufficient. Strengthening provider competencies and creating a youth-friendly environment were necessary to increase the service uptake. The broad objective was to increase uptake of family planning services among adolescents aged 15 to 19 years at Kegondi Health Center through the implementation of provider training on adolescent and youth-friendly health services. Specific objectives to improve provider competencies in adolescent youth-friendly health service delivery, enhance quality and adolescent friendliness of family planning services to increase family planning uptake among the adolescents. Then to evaluate the impact of provider training using routine service data. So the interventions, the provider training, it was conducted in 2020, improved AY, FSH, FHS knowledge, counseling skills, and respectful care. Then dedicated adolescent clinic hours. We created a youth-friendly environment for confidential services. Then privacy improvements. We ensured confidentiality and reduced the stigma. Enhanced counseling, provided individualized adolescent-centered family planning education. Then strengthened referral system, linked adolescents to specialized care when needed. Then the intervention addressed both provider competencies and the service environment. The study setting was at Kegondi Health Center, which is a primary healthcare facility, Sabate Sub-County, Vihiga County. Methodology, retrospective review. We compared adolescent family planning service uptake before and after the intervention. So data was obtained from KHIS data, extracted and analyzed routine family planning service data from the Kenya Health Information System, and structured questionnaires, collected information on provider competencies, adolescent experiences, and their client satisfaction. So the project combined routine health information system data with questionnaire findings to evaluate whether provider training translated into measurable improvements in adolescent family planning service uptake. That one I read before. So the results, before intervention, we had 2018, 56 adolescent, 2019, 36, and then 2020, 52. So 2020 is when the training was done with the help of TCI supporters. So after intervention, 2021, we had 70 adolescents, 2260, 23 69, 24 71. So key findings, there was 94.4% increase in adolescent family planning uptake immediately following provider training. Then service utilization remained higher than baseline throughout the follow-up period. The intervention was associated with a marked improvement in adolescent family planning service uptake, demonstrating that strengthening provider competencies and creating a youth-friendly service environment can substantially improve access to reproductive health services. That is a budget. So attendance was low and variable before the intervention. Then there was a sharp increase occurred immediately after the provider training. Then attendance remained consistently above baseline through 2024. This trend suggests a sustained positive impact of the quality improvement intervention on adolescent family planning service uptake. Before provider training, adolescent attendance fluctuated at relatively low levels. Then after provider training, attendance increased markedly and remained consistently high over the following years. That one have been discussed. And recommendations: scale up, expand adolescent youth-friendly health service provider training to other health facilities, continue mentorship, conduct regular refresher training and supportive supervision, then commodity availability, to maintain uninterrupted supplies of family planning commodities, monitoring and evaluation, strengthen routine data review and quality improvement. Then this quality project demonstrated that provider training on adolescent and youth-friendly health services was associated with a substantial increase in adolescent family planning service uptake at Kegondi Health Center. Thank you.
I hope you are taking questions so that we can have a Q&A session after this. Next, we have Benson Kinywa. Yes, we don't have Benson here. What about Charity?
It's Sharon, I think.
Sharon.
Yeah, Sharon.
Sharon.
Yeah, Sharon.
Sharon Chepkirui. Sorry for that.
Good morning.
Good morning.
My name is Sharon Shekiru. I'm a registered nurse currently based in Home Teaching and Referral Hospital. Thank you for the opportunity to present my study. As per the theme of this conference, advancing patient-centered and respectful maternity care, I'm presenting lessons from family-centered care in intensive care unit setting. We appreciate that we have mothers who are admitted in the critical care unit, and most of them receive care. And I know the findings from the study are important in the in the provision of care to the pregnant women. So, to the background of the study, we find that family-centered care is an approach of planning care and also delivering and evaluation of care based on partnerships between healthcare providers and the families of patients admitted in the critical care unit. So when we talk about family-centered care, I will be referring to FCC. That is the short form for family-centered care. So FCC acknowledges that family members possess unique insights into patients' needs, which impact their overall well-being. We also find that FCC in the ICU allows family members to communicate the patient's preferences to the healthcare team and serve as a surrogate decision maker. To the statement of the problem, we find that literature demonstrates that FCC improves the overall satisfaction of family members in the critical care unit. But we have very limited evidence examining the same in Kenya, and especially in the hospital I did the study, that is the Moi Teaching and Referral Hospital. To the justification of the study, family-centered care leads to improved patients and families' experience with care, and hence influence positively the outcomes with care. There is improved interactions, relationships, and communications between the healthcare providers and the families of patients admitted in the critical care unit. My general objective was to assess the relationship between FCC experience and the family satisfaction among family members with patients admitted in the critical care units. And to the specific objectives was to determine the overall level of family-centered care as experienced by the families in the critical care unit. And then I was also going to compare the mean in the subscales. We find that the family-centered care has 4 principles, that is communication, collaboration, dignity and respect, and also participation in care. So I was comparing the mean score within the 4 principles. And then the third objective was to examine the association between family-centered care experience and family satisfaction. And then finally, I was to identify family and patient characteristics associated with variations in perceived family-centered care during the period of study. The study design was a cross-sectional correlational study, and then it was performed at the Moi Teaching and Referral ICU, adult ICU. The study population were family members of ICU patients, and then the study sample was a total of 300 eligible family members, and we had a self-administered questionnaire, which is a validated FCC ICU and a validated FS ICU 24 questionnaire. The data analysis was descriptive statistics. We also had a Pearson and multi-linear regression. To the results, we saw that 73.7% of participants reported high family-centered care experience, while 26.3% had low family-centered care experience. And respect and dignity had the highest perceived percentage among the patients admitted in the critical care unit. Information sharing came second, and then collaboration third. Participation in care was the lowest rating. So we find that in the discussion, information sharing significantly predicted higher family satisfaction. Participation was significantly negative, and we find that most family members did not participate in care, and that could be attributed to several factors in the critical care unit. Age also demonstrated a moderate positive correlation with the total score. We find that the family members who were advanced in age reported to be more satisfied and to have experienced family-centered care in the critical care unit. Education level also was significantly associated with perceived family-centered care, and respect and dignity was the strongest independent predictor of family-centered care. That means when we treat family members with respect and dignity, they report to be more satisfied with care. And now, how can we apply the family-centered care approach in midwifery? We find the principle of respect and dignity, where we are supposed to treat the women, we are supposed to respect the women's autonomy and preferences to their birth and birth preferences. Also, we are supposed to protect their privacy and confidentiality. We are supposed to provide care free from discrimination. We are also supposed to treat their family members as partners in care. In the communication and information sharing, we are supposed to explain the labor process, discuss intervention, and obtain an informed consent. We're supposed to prepare family members for newborn care, and also educating the mothers on danger signs, breastfeeding, and postnatal care. In the participation of care, we're supposed to allow birth companions during labor where appropriate. We're supposed to involving partners and family members in newborn care and also education. We're supposed to support family involvement in postnatal and discharge planning. In the strengthening of collaboration and decision making, we are to practice multidisciplinary teamwork, involve women in decision regarding induction and also cesarean sections. To my recommendation, we should have timely, clear, and culturally appropriate information to women and their families during antenatal care, labor, and delivery. To further studies, we could conduct studies to evaluate the implementation and effectiveness of family-centered care in the antenatal, intrapartum, and postnatal settings. We can also explore the barriers and facilitators to implement family-centered care in the maternity units. In conclusion, family-centered care is associated with higher family satisfaction. Respect, communication, and partnerships are central to quality care. So as much as the study was conducted in the critical care units, these principles would also reinforce respectful maternity, where we should communicate effectively, show women respect, collaborate with their family members in care, and also participate in the care. That was my study, and thank you for your time.
Is Benson with us? Benson King. If he's not with us, we can have the next presenter. Charity has already presented. Catherine Wangoi. And we'll appreciate all the presenters after this because we are not appreciating them. And they're doing a very commendable job. So tuweke hiyo makofi yote pamoja, we'll give them after the presentation. Wakati watakuja hapa mbele, si ndio? Catherine. We have heard of about respectful maternity care, and we are doing that for the LCG, sindio? Labor care guidance. We are having what are we calling them? The partners. Ja kitambo ulikuwa unaona tu mwanaume, nakumbuka nikiwa those years nikiwa college. Mwanaume alikuwa anaambia kaa huko kando. Mwanaume unafanya nini hapa hivi? Tumetoka mbali sana. And with that stigma yenye watu wanakuwa about nurses, unaona some comedies zenye zinafanywa na watu kwa TikTok. Those were nurses wa kitambo. It is not us. Ama kuna mmoja wetu kweli anafanya hizo bado hivyo. Those are old days. Those days, I think we should also have our nurses doing those things on TikTok. What nurses are now doing. Si kama kitambo. Like nurses walikuwa wanajulikana talking to patients, doing what. So the comedians are imitating those old nurses. Wajue sisi sio wale nurses wa hiyo wakati. Mambo imebadilika. Karibu Kate.
Good morning. My name is Catherine. I am a nephrology nurse presenting a case study on outcomes of timely initiation of dialysis for patients with Praki in Kitui County Referral Hospital. We have been doing a follow-up with my colleague, who's Elizabeth Musili, midwife who works in the postnatal unit. So to begin with, today, our main objectives for this is to know what Praki means. The clinical presentation of Praki, diagnosis, the challenges of management, the achievements, and also the recommendations. So, PRAC refers to pregnancy-related acute kidney injury. I was following on all your presentation, and most of you are asking, how come there's a sudden increase of AKI with pregnant women? And this is a relation of understanding what PRAC means. Pregnancy-related acute kidney injury is a sudden decrease of kidney function during pregnancy. I want to also recommend that the discrepancy of measuring the UECs for a pregnant woman can have variance because the woman is not in a normal position. You cannot use the normal lab works that you usually use. So this refers to a rise in serum urea of 0.3 or 26.5 millimole, serum creatinine increased by 50%, and also reduced urine volume by 0.5 mils per kg per hour over 6 hours. prevalence. The World Health Assembly adopted the first resolution on kidney disease, recognizing it as a global public health priority and calling for strengthened prevention, early detection, and equitable access to care across the life course, including in pregnancy. You can bear with me that in all 47 counties, we have limited renal units that have very few bed capacity of 5. So it's quite a challenge with all the sudden absence of women with trach. At Moi Teaching Referral Hospital, a study on AKI shows that AKI in severe preeclamptic patients were at 26.3 and increased the incidence by 4.4. That means 14.3 required dialysis. 37% of 2 or 3 mothers with brachy in KH were initiated on dialysis. 79% had less than 4 antenatal visits, and we are all aware that the antenatal visits have increased. So when they have fewer ANC visits, that means the monitoring becomes difficult, and it's very hard to identify or pick up the baseline mark where we can start following up for AKI. 33% of the deliveries occurred between 33 and 37 weeks. That means most of these mothers end up having preterms. KNH also cites that pregnant women with brachy have less referral from rural or lower facilities with advanced kidney injury at stage 3 of kidney growth. This means that our referral system also has a lack that needs to be addressed. Some of the predisposing factors that result to brachy include preeclampsia, hyperemesis, postpartum hemorrhage, antepartum hemorrhage, postpartum sepsis, HERPS syndrome, and pyelonephritis. This is just a diagram to show the various places where you can develop how AKI can come in. Pre-renal, renal, and post-renal. Pre is before anything that gets to the renal, into the kidney. That means if you have anything to do with hypotension, you have anything to do with BPH, hyperemesis gravidarum, anything that will reduce the volume to the kidney can result to acute kidney injury. Intrarenal means inside the kidney, what happens inside the kidney. You might have infections, you might have drugs that are nephrotoxic. We also may have prolonged hypotension and also inflammatory diseases that may result to kidney injury. And then postrenal refers to an obstruction. Your kidney can perform the basic need, but the output is obstructed, and this can lead to AKI. I am going to present a case study for us to understand better what brachy is. A client with MN, 30 years, para 2 plus 0, gravida 3, was admitted on 18th of May this year as an emergency after collapsing at Huduma Center with complaints of headache, heavy gastric pain, and vomiting. On assessment, her LMP was on 16th of September 2025, and then her EDD was on 23rd of June. She was 40 weeks by gestation, ultrasound, and had 0 antenatal visit. One of the challenges that you'll see most of the mothers, yesterday we talked about mental health. So this mother had issues at home that made her not attend any antenatal visit, whereby this made it difficult to have a baseline survey of knowing where the practice set in. On physical examination, she had edema, nil jaundice, no pallor, fundal height was 34, the lie was longitudinal, and the rest is normal findings apart from the BP, where we get it was at 144.94. Investigations done, the ultrasound was done, confirmed 40 weeks. LFTs showed low albumin, assault and LP tests were high. For hemogram, the only significant part was on the platelets were dropping. UECs, urea was high at 9.8 and creatinine was high at 238. Potassium was normal. Urinalysis showed protein plus, blood, and leukocytes were present. Management, the mother was being managed with magnesium sulfate. Methyl dopa was started. An emergency CS was done. Urine output was noted to have decreased to 50, and IV fluids were started. At then, the diagnosis was severe PET with HELP syndrome. Moving on, day 2, after delivery, the mother is okay, the baby has been delivered. We note that the BP has gone back to normal, 108.82, and the pulse rate was 88. But on repeat of the full hemogram, the platelets had dropped to 27, and the HB was at 8.5. We continued to challenge the kidney with a dose of 40 milligram of Lasix, and the output increased slightly to 100 mils. We continued with post-wound care, pain management, and PET management. By day 4, the mother had another different presentation, and this is where our mother was landed to ICU. She presented with DIB, saturating at 77. She was pale. Ecchymosis was noted at the incision site, periorbital edema, and the urine output again reduced to 50. Urea was high at 13.7, and UCs were high at 704. HB had dropped to 5.7. We could not have a clear picture of the platelets. Then after transfusion, after the 3 sessions of dialysis, because we usually initiate the first 3 sessions, and then we plan for the subsequent session. This is how our mother presented. After 3 units of blood transfusion, urea had gone down to 10.3 and creatinine 583 from 704. HB from 5.7 had risen to 9.2. No ecchymosis was noted. DIB was resolved. Output had increased. Activities of daily living. Remember, this mother just collapsed, came in. Our first initiation was to bring out the baby and make sure the mother and the baby are safe. That was achieved. However, the kidneys were failing her, and if she was not in our setting, she would not have gone through this. Then, after resolving all this, the mother and the child were able to bond, and breastfeeding was established. Further investigation after the window period and on monitoring, LFTs improved. You can see the albumin has risen to 45 from 3.6, and the assault test has also gone down from 700 to 31. Full hemogram, to note of significance is the HB and the platelets from 27 to 310. Urea had also decreased further to the normal rate to 3.67, and creatinine had gone back to 86. Potassium was normal, and urinalysis findings were normal. Our achievements. We noted that collaboration between the postnatal with the renal team and the IMED department helped, because in as much as the mother has kidney failure in the maternity, it's hard to get somebody to put a catheter to monitor. The ICU team was also involved in this care. Then, good maternal outcomes. Most of these women die in facilities or in areas where they are not able to access renal units. So, good outcomes and neonatal outcomes through management of severe PT, anemia, and AKI. The mother's life was saved, and the timely CS ensured the safe delivery of the newborn. AKI reversal. In other settings where there are no dialysis, the AKI can further progress to chronic kidney failure. But with a timely intervention of hemodialysis, it ensured it salvaged the kidney function back to its optimum rather than progressing to CKD. Staff. Dedication of the renal nurses from the unit and having a renal midwifery nurse. You see, we are now clustering ourselves as a nurse midwifery, and sometimes we can disintegrate. We'd rather collaborate, all of us, and work together so that we can pull each other. When you notice these discrepancies, it's easier to call the person that is next rather than focusing on midwifery alone. So through this, the dedication has ensured a good outcomes and helped planning of care for the mother. Collaboration of the OBS-GYN and IMED team also helped the mother, the management of the mother. Challenges. Drugs. You can notice that when we were challenging the kidney, we used 40 milligrams of Lasix instead of 80. This is a deficit of knowledge for some of our healthcare workers, since we have identified specialized areas that belong to different categories. Staff. Most nurses and healthcare workers in maternity are unfamiliar with acute kidney injury setting and management. Most updates revolve around safe delivery, management of PPH, newborn resuscitation, limiting knowledge to other complications. Correlating OBS-GYN medical and renal services by time for prompt move that is required. That means the consultant in gynae has to call the consultant in IMED. They have to organize for a bed. They have to organize for a space. So it really buys on time when you're doing all this collaboration, because when do you get to pick all this when you're focusing on one area of healthcare? Investigations, as we can all attest in public facilities, it's very difficult to have all the tests at their given time. So you find you have UCs, you don't have a full hemogram. You have you can even lack the basic of urinalysis. But these are the things that make us miss the point of early identification of AKI. ANC, as noted, poor seeking services of preconception care and ANC services put the mothers and the fetus at risk, since there is no monitoring, and it also results to late referrals. Some of us who work in tertiary levels, you will find a mother who has high BPs, and the staff at the lower level tells the mother, pick the next matatu, go home. This seeking services and reduced NC visit, and also lack of putting UCs as a baseline in your ANC. Finances. Most of the Kenyans have limited finances and have not taken up the basic insurance that can assist them to pay for essential health services. Referral. Limited space of specialized care, i.e. renal services, ICU, demoralized staffs, and inability to control. Our recommendation are preconception care and ANC should include serial monitoring of kidney functions tests, to have baseline follow-up, and also for prompt referral in case of any deviation. Continuous medical education on kidney injury should be incorporated in MCH, gynae, and maternity department. Family planning teachings should include monitoring of kidney functions for mothers who develop PT or AKI. Outreaches and community mobilization and teaching kidney disease can help community care workers identify clients developing kidney injury. Optimal early referral from lower facilities can save outcomes of kidney disease. The HMS should capture incidences of AKI in pregnancy in order to have relevant data to help in policy planning. These are the reference, and thank you for listening.
Thank you, Catherine, for the presentation. Personally, nimesoma sana. I don't know whether the rest have done a lot. That's why we are here. And a lot of key take-home messages. One, you've heard about AKI. We are concentrating so much on the PPHs, skill deliveries, and those small things like AKI. We are not talking about them. Then we are losing our mothers or even getting some complications. So when we go back to our facilities, I know we are having the chair of RH coordinators. I know that message she's there. We'll get back to your fellow RH coordinators in the country, because I think in the awareness, that is something that we should incorporate. She has also talked about DHMS, us including that in the data, so that we can get information and maybe for decision making. Our nurses working in the MCH being empowered on AKI, so we're also teaching our women about the NNAK. So thank you so much for the presentation. It is an eye-opener to many of us. I think you've also told us about the preconception care, So thank you so much for the presentation. Asante sana, Catherine. Next on stage is Josephine Ideri. Is he around? If he's not around, we can have Ben Mutiria. Ben.
So good morning. As good morning. My name is Ben. I work with Kenya Medical Training College. I'm currently in Meru campus, and I'm a bit nervous. I'm a bit nervous. I'm usually nervous, but I'm fine. So let me talk to the men. I want to talk to the men on this one. I realized that reproductive health is about women, and the theme here is bringing in the men. So we did this study in Trans Nzoia County with my colleagues. Lydia is a nurse at Kitale, is a lecturer at Kenya Medical Training College. All of them are lecturers at Kenya Medical Training College. Kitale, Christine Okuta is in Karen campus, and Olga is also in Kitale. This study was supported by Micro Research Canada and Kenya Medical Training College. Now, reproductive health and reproduction mainly is about men. I'm just giving a story on the introduction. It's about women, and men are like the chair of the day said that ukifika unaambiwa ni sawa sasa tuachie, si ndio? And now figure a situation where you umewaachia and then probably the baby gets asphyxia, taken to NBU, and probably after 4 or 5 days the baby dies, God forbid. But then the question is, the only time you see this baby is either as you sign the disposal papers or as you are out in the mortuary. And the only thing you are left being told are stories. Ati macho ilikuwa kama yako tu. Hata masikio ni kama unaona ile yanko yako. So they are just stories that you are told about your baby. And men have taken a back seat in the reproduction. Now figure out a situation whereby because studies have shown that the husband being present or the partner being present actually helps in psychological management, pain management, and better bonding. You're there when your sperm output comes out. You know, as the sperm output is coming out, you are the one receiving the output. It becomes a very nice thing in bonding. So the question comes in, like, we really wanted to find out why, if men were okay being present when the baby is born. Now the labor care guide provides for a birth companion, but specifically this birth companion does not mean the husband. And in most settings, is either the mother-in-law or the sister-in-law or the mother or the sister. It's usually a women affair. Kuna colleague wangu tulipatana hapo akaniambia hii bag nimepewa nikapea my wife. Sijasema kwamba the reproductive health is more female. Yeah, it's just female. Even the VC said it's going to give to the wife because it's more female than male. So we wanted to find out what are these factors that would actually influence your husband, even the men seated here, and how would you really want to be there when the baby is coming out? I mean you, like the midwife. I know someone who is an ops guy but refused. So we wanted to find out these factors that would influence our methods. We chose Trans Nzoia County. Mainly Trans Nzoia County has 2 major communities residing there. So there was a multicultural aspect there. And we used both, we had, I'm going to present the quantitative data, but we had also a qualitative data. And we wanted to find out among married people, if you're married and you're living in Trans Nzoia and we had 144 as our sample, both 72 men and 72 women, and we sampled in all the 5 sub-counties of Trans Nzoia. We included women and men who have had a baby. So if you are married, even if it's for 20 years, but you have never had a baby, you are excluded from the study. And we had also to talk, it was a community-based study, so we used 18 years and above. And the results, because that is where I probably want to talk more, the gender is equal. The age, we had so many of them, 144, but the highest number was actually the 26 to 35. And out of this, you can see, out of the age bracket of 18 to 25, 12 of them out of the 33, that is 36.4% of them were present during delivery. The husbands were present. Either the wife reported that my husband was there, or the husband was actually there. Well, 63% were not. Another percentage goes down all the way to 46 plus, where only 16% were actually present during the delivery. And education, those that had tertiary had at 40%, 41% of them were actually present, those that have gone to college and above, as opposed to 18, actually there were 17 for those that have gone to primary school. Occupation was also significant, though I've not tabulated the number that was actually present. Now, these are the statistics. Younger men between 18 to 25 were more likely to be present than older men. 46, probably they have seen a lot. The 46 and above. Umezaa watoto watano. We had one who had 15 kids in our survey. 15 of them. Yes, but was of course man. Women can't have 15 at this age, but men can have 15. They had 15 children. So maybe 46 and above are seen a lot. So the younger ones are more excited about my baby. And then, of course, comparing tertiary and primary or not formal, that those that have gone to tertiary were three times more likely to be present as opposed to those that were in primary. While those that were in professional employment were 4 times likely to be present. There was no really significance in terms of Christian and non-Christian. And this is just explanation of the statistics that I've said. But those are the other factors that are actually drivers in terms of individual factors. Years of marriage and the number of children. These were not really so much significant. Let me show you what I mean. Those that had one child were 21%. 2 children, 26% were present of them, and then 3, 25%. When these are some of them, you find that they may not be very significant because of the numbers that we in the cohort. Like for example, there's one who had 15. I said 15 and was not present. The 15. Of course, if you are 15, would you even be present, or you will jump that pregnancy? So there was no really significance between the number of children and the number of years married in the presence. Now, the experiences on the qualitative data here, the experiences of the people who are present. One, most of them, 10 of them, reported emotional support and encouragement. 10 of them. 9 of them felt joy. When we did our focus group discussion, one said, nikikuwa hapo, hawawezi iba mtoto wangu. But he said in wale nurses wa kitambo. So it was like, hawawezi iba mtoto wangu. So, but there was a lot of joy. When we also had anxiety, we found that some feared blood, some had negative experiences because of blood. And sometimes if your babe is crying so much, you sometimes feel not so bad, not so good. You feel like you would take her to give birth on their behalf. The reasons for not being there, actually, that were given was actually job. When we were doing this study, one of our colleagues was actually pregnant, and when we were giving report, the question was the husband present? And he said, no, the husband was not present. Like, why? Job. So job was top number one, and especially for the unskilled ones, because kama we ni makanga, would you leave school when you have maternity ama utaenda school? So that is what, and again anaambia wewe enda utafute, ukifika unaambia enda utafute pesa tunakudistadi kesho, wewe enda utafute pesa. So job became number one, that was preventing. Then we had cultural beliefs. Among the Kalenjin, because Kitale has Kalenjin and Luyas, among the Kalenjin, it was a taboo that you are around where the women are giving birth, and you only be called after the baby is born, after some like 3-4 days. That is when you will come to see your baby. Among the Sabauti, actually, it was supportive. The culture encouraged the husband to be there. So traditions also were actually one. And then we come in there. 28 of hours were the reasons why the husbands were not there. You come in and unaambiwa, wewe toka tu umetuachie sasa. The policy does not allow, of course, because of the infrastructure. In the hall, it's a hall and every woman is giving birth. Would you allow the husbands to see other people's murima? So we would not want that to happen. So that was also another one. But then there were also those that were actually feared. They feared being there. And also, some of them didn't know that I'm supposed to be there. Akishamwambia unaumwa tu enda hospitali naendelea na hustle. So that is and then we had the distance. Now in conclusion, education is a predictor. Education. Whereas we are looking at the formal education, primary, secondary, also knowledge, educating the community. Occupation also is a significant, and encouraging people, the employers and supervisors here, please allow us men to also go and give birth. Just give us time. Let's go and deliver this baby and come back. Age, younger men are more, and sometimes actually the pain management, one has a post at a video TikToks, downloading manenos and then hashtag imewekwa hapo, and then they enjoy that as opposed to older men. Religion was not significant, and also the number of children and the duration of marriage was not actually significant. But most of them, 59%, actually described experiences that are positive being present, while others actually reported nervousness, fears, some mixed reactions, and others actually negative. So we would recommend that we sensitize hospitals. Sometimes you may think that maybe private have provisions. The answer is no. Even we found somebody who was present in a public, public facility, health center. He's the only one delivering that neighborhood in that health center. So alipofika aliambiwa ingia tu, and then we asked, how was it? He says that was the best ever. Yeah. So provisions for that in the hospital, and also empowering men to be there with knowledge. Let them know that they are also equal parents. Thank you so much.
Thank you, Ben, for speaking for the boy child. I know the labor officials will incorporate that. We'll be getting like 30 days of, instead of the 14 days, 30 days. Sindio? You start from the labor ward up to, or even 6 weeks. Because PPM, you know, we go back to work after the 6 weeks. Next is on stage is Josephine. I don't know if she's around. Okay, Karibu Josephine.
Good morning, everyone. I'm Josephine Hereri, a nurse working at Chuka Level 5 Hospital, the Bound Department, and also a student here at the university. topic that I'm about to talk about is self-breast examination. Is a study that I conducted last year at Chuka Level 5 Hospital about self-breast exam. I know we cannot agree that this is a challenge to all of us women, that we are a bit reluctant of conducting self-breast examination, and it is the method that you don't spend any cent on it. It is free, it's cost effective, you use less time, but then we don't practice it. And it is a concern that rose to me that we need to check out or investigate or dig further why people don't like practicing this thing, yet it gives us early results or early diagnosis, or it helps us to know that there is a problem that is loading and yet is minimal, it's minimally practiced. So I did a topic on determinants of self-breast examination practice among women attending family planning clinic at Chuka Level 5 Hospital. And this is a study that I did on at the women attending a maternal health clinic at Chuka Level 5. And we all know that breast cancer remains significant public health issue globally. The statistics shows that it keeps on rising each year, and globally it accounts for 11.6%. That is accounting for 6.9 cancer deaths. In Sub-Saharan Africa, the most of morbidity and second leading cause of cancer deaths among women is breast cancer. In Kenya now, most diagnosed cancer among women accounts for about 25%. And when you look at these numbers, they tell us that we need to do more and to try and recap this trend so that we could see if we could reduce the prevalence. And according to the World Health Organization, by 2040, breast cancer mortality should be reduced by 40%, especially among women who are under 70 years. And breast cancer screening, particularly for clinical issues, is not even practiced. For example, when a patient comes to clinic, let's talk about women now. When they come to clinic, how many clinicians do breast exam? Very few. So it is overlooked, whereas it is very important because it guides us. The three pillars, according to WHO, for managing breast cancer is timely diagnosis, comprehensive management, and health promotion. And when it comes to countries that have low income, this is the best method that we could use, because when we talk of screening, unless there is a free screening, you have to pay money. And most of people cannot afford that. So as health workers, it's upon us to know how can we help these mothers who visit us to detect these symptoms very early before they progress to something that will require a lot of money and financial burden. As I've said earlier, in Kenya, the leading cause of cancer-related deaths among women, accounting for 16.1 in all cancer cases, is the breast cancer, and the mortality of the same is 12.5%. And the National Cancer Control Strategy highlights the need for improved early detection and screening strategies. The self-breast examination, as I've said earlier, it remains low because maybe there is limited awareness, That is the work of us health workers to mobilize people to conduct campaigns. And another thing may be cultural misconception. As you know, there are areas or there are parts where women don't trust that you could examine their breast, or they believe that I cannot hold my breast to check it because that is culturally not accepted. And also there is health care accessibility barriers. There are people who live in remote areas away from areas that they could access health facilities. You understand? Despite national efforts to promote early detection, there is limited data on prevalence and determinants of SB at county level. So at even the county levels, there's a lot to be done. And I just wanted to evaluate the determinants of self-breast examination among women attending family planning clinic. That is, I wanted to determine the number of women practicing self-breast examination. I wanted also to determine the level of knowledge of self-breast among women. Also, to determine the socio-demographic factors influencing self-breast practices among women attending from family planning clinic, and to determine the cultural factors influencing practices among women attending family planning at Chuka Level 5 Hospital, and also to determine the relationship now between the knowledge level and the practice of self-breast among women attending family planning clinic at Level 5 Hospital. Those are the research questions. The methodology I said is I did it at Chuka County Hospital. I used cross-sectional design. The target population were all women who are attending maternal clinic, FP clinic, and then who are visited for healthcare promotion. And the sample size, I sampled 129 women and 6 healthcare providers. And the data collection, I used questionnaire. And these were the results. The most age of the clients who visit the clinic were between 18 and 54 years. So majority, the mean was around 26 years, and majority of the participants were learned, that is, they were above tertiary education, and most of them were the Catholics. Employed were 27%, students were less. The parity were most had 2 children. Family planning, the most that were using was implants. And most of them, they had no history of breast cancer. From the key informants, I used the clinical officers, the gynecologists, and the nurses, of which majority were the nurses, and most of them had higher diploma, and most gender was female. So this, according to the data, most of the people said they performed self-breast examination regularly. That was 66.1%, and that percent said they don't do it, and most of them said they forget. About the practice, 83% said that sense and things, they were aware of what they were looking for, the lumps, the nipple discharge, and about the socio-demographic determinants, tertiary education were less likely perform. You can hear this. I want you to note this. The people who are most educated were the least that practice self-breast examination, including. Yes, that's a point that we should note, that yes, it's true. That people who were not educated, according to my data, were people who practice self-breast examination, a point to note. So that's a research that can be done by another person. Why? Those who are educated don't. And it's a topic that I wanted to do with the prof. Why health workers don't, okay, you know. On knowledge, most of the participants were aware of self-breast examination, that is 92.2%, and they agreed that with early detection of you can detect breast cancer 90% when you practice it early. And according to this were the data for social-cultural practices, and you can see the figures. In my culture, discussing breast cancer is considered inappropriate. Those who agreed were a lot. Women in my community are discouraged from performing. That's the data. And I would just go to conclusion. More than half of women practice self-breast examination. Majority do it monthly and at recommended time. Lack of awareness of the correct steps was the main reason for non-practicing. General awareness and specific knowledge on self-breast was high. Majority of women had good knowledge and level of practice was good. Gaps on the current steps of carrying out self-breast exam and identifying some signs of breast cancer, such as changes in breast size, they were aware of that. Level of education and source of income was significant predictors of self-breast examination. As we have seen, the educated people practice it less. Women who agreed that their family encourages them to practice self-breast exam were significantly 0.4 times and more likely to perform self-breast examination. So even family, there are families that if you have an encouraging husband who tells you that it is important that every month those women who are at support system practice self-breast examination more than those who had no family support. Participants with higher knowledge level were more likely to practice compared to those with poor knowledge. So that was all about my study. Thank you very much.
So, thank you very much. Wale tuko educated, we don't like doing it. So, si tutafanya research tuone ni kwa nini prof. Because tuko na knowledge, lakini hatutaki kufanya hiyo maneno. Si ndio? Lakini mama huko sokoni anafanya hiyo maneno. Sawa sawa. So, thank you very much our presenters of the day. I think we can break for tea. And then we come for Q&A after that. Sawa sawa. Can have 5 minutes maybe to tusikie kitu from prof before tutoke kwenda kwa chai. Thank you.
Good morning everyone. Mko sawa? Sasa wengine walienda nyumbani ama wanakuja? Lakini jana tulikuwa wengi mpaka I was like wow. And even today I'm so happy. It means that we value information and knowledge. Si ati niliwatupa, nilikuwa nafanya some logistics. You know hii kitu imeni overwhelm. We first Collins had told me to budget for 50. Tukafika pale nikaona 70. Tukafika pale nikasema 90. Sasa jana 130 something. Nikasema kumbe nazo hizo walikuwa wamekosa nyumba ya kuingia. Sasa wamepata RH. Me I'm just happy and I want to say that I'm encouraged because when we started planning in June tulikuwa tunaona kama hatutapata abstracts. Are you seeing the type of abstract we have? Are you seeing that? Nurses. It's only that you are all not Kikuyus and Merus. Kuna kawimbo ningewaimbia because I love singing. Hapana, nani ataitapetia wengine? Wataona kama nimekuwa mlima. Nimekuwa mlima raised. And therefore, sisi wamama wa Women's Girl tunaulizanga in Kikuyu, why you despise yourself? Wale wako Women's Girl wanajua kaemwe iragane kenaneke kaemwe uraganeke nanego muliandwangaka alume mwimbere. You don't know. The song says, why would you I've said alume because you see tunaimbanga tunasema wamama. Unajua ni wamama wangelu. Wamama tuko wamama. And now today through men and the others tumeona wanaume wako. Mungejua kama men celebrate the output of their sperms. Na wajani niwaambie. I'm just buying time in tea. And by the way, most of you have never seen me. Mulikuwa naona tunaambia hi my loveless kwa mtandao. And by the way, do you know these conferences are very good? Yes. Sasa kama wewe Joyce Meti, when did you lastly laugh? Ukiwa kwa hiyo ondi yako ama maternity ama wherever. Hauna wakati wa kucheka, and you know laughing saves a lot of our lives because inaongeza siku na inatufanya tukue younger, si ni kweli? Because every time uko hivi you use more muscles than when you're smiling, si ni kweli? That is what the psychologist said. So me, I'm just encouraged and I want to tell you, let us embrace education, let us embrace continuous learning, lifelong learning, because we get to learn new things. I'm sure hamtarundi vile mlikuwa. Na kama kuna mtu mwenye atarundi akiwa vile alikuja, who want you? Ini kwetu tunaulizanga ya kwa teknolojia imekufa nini? Tunaulizanga hivyo, kukufa nini ni kana kwamba hiyo pesa yako yote umetumia. Imagine umekuja mpaka Chuka. First of all, you have been into a prophetic university. The only prophetic university in the whole world, by the way. Simulisikia Professor Nduru akisema, si stories za Java, real stories. That lady anaitwa Jerusha Kanyua. Alikuwa midwife, traditional. Alikuwa anatembea mpaka Chogori ya kutibu, conduct deliveries. You know, those ones who have learned the history of nursing and midwifery kwanza, you know, qualification ilikuwa kuongea lugha yako, hivyo tu. Na sana ilikuwa Kikuyu. Si missionaries when they came, by the way, walikuja mlima. Before waende now, huko Musoriot. Ingine ilikuwa ni tangu aje when wanajua history ya nursing and the missionaries. I'm now teaching. Mwanda Musachi Mwanda, because I love that history, so that we see how they came and why some places are more developed than others. Because those missionaries, they came for 3 main things. Free lecture from me now, I'm lipi fee. 3 main things. Ya kwanza ilikuwa nini? Wale wamepitia kwa mikono yangu. Ya kwanza ilikuwa nini? Education, isn't it? Ya pili, health care, very good. Ya tatu, spiritual and eradication of poverty. Sindio? And mpaka saa hii hizo vitu tatu zinatukula. Si ni kweli? Why? The missionaries came and they left. Did we forget what we came for? And therefore, that's why you are here, in search of more knowledge. Sindio? Unaona Mungai yako pale? Mungai, I salute you. Imagine she's a chair of wound care and the rest. I am not able to pronounce the others. Hizo zingine. But I want to tell you, unaona vile tunapendana. Si hata maternity tunakutanga vindonda. Kwani hakuna vindonda? Episiotomy si kidonda. CS kasi kidonda. I mean CS is kidonda. Sasa unaona the way you can still be in RH and you are in wound care. Na unaona nazingaza sasa imeifanya a specialization. You can just specialize na hiyo ma episiotomy wounds. Tulisikia visini professor wa Bidibindo. nitamtembelea sana nijue what it is. That's increasing that libido, especially on us who are now over 50. Amukupata hiyo mlipitia na hiyo. You had better invite him so that he can tell you more about now what he specializes in specifically in that libido. And I'm encouraged. I'm so much encouraged because nimeona ya kwamba tumesoma hapo nje, tumesoma hapo nje, tuko na knowledge, na ndio sababu watu wa media nisione hii nasema me I put a disclaimer, but ndio sababu naambianga my students that tusiende tukifuata hao wa colleagues nyuma, ukimuita mtoto wangu, ukimuita my brother, my son. There is no brother, there is no son in the profession. We are colleagues who are complementing our services. So if somebody does not see your work as a complementary contribution, forget about that person and claim your space. Yes. Do not be at the back. Do you know why you are always following them behind? Juu hamujasoma. Ujui unaogopa kuulizwa swali. Unaogopa kuulizwa hii patenting tunampea inafanya kazi gani? But if you know what patenting does, the mode of action, pharmacodynamics and pharmacokinetics, I'm telling you, utakuwa hapo mbele. Yes. I tell my nurses when nataka chai kuje msijali. I tell my nurses and my students when I'm training them, when I was in charge of a certain facility, I think when I was 27 years old, and I want to tell you all doctors were reporting to me. Those who work there know they were reporting to me kwa sababu mimi nikuta mtoto wako nambani na naambia mama apeane oral fluids. Ni oral fluids gani huyo mama ataoreva yenye iko na all those components. Mwingine anaandimeti mgonjwa kutoka kwa private clinic yake, anamwambia usiguzwe na hao manasis. Nampigia simu namwambia come and pick your patient, go with her to that private hospital. You know, when you know things hakuna mwenye atakutisha. And you know you are the people we train you on teaching methodology na kila kitu. Wao hata hawajui kuset exams. Wako hivyo na nyinyi mko hapo tu mnasema I'm just a nurse. Are you just a nurse? Hii kazi nani mwenye anaweza aleta kama hii? Si mnaendanga conference, I'm not telling them that they are banned, but they have to respect us. And how do they respect us? They respect us if we claim our position. Ingine nataka kuambia because tukifunga sitaongea sana, let us be united. Usione Professor Lucy amesimama hapo nauliza sasa hii ni nini itatoka kwake. See your colleague as a partner in business. Yani, the way you see your sibling, the way you see your sister, your brother, it's how we should see each other as nurses and midwives. Because nursing and midwifery is our business, nothing else. Hizo zingine outside there tuachane nazo. And you know when you are like this, unajua tutaenda mbali. Lakini tukikuwa hivi, tutafika wapi? That's how the enemy will come and attack us. Including sasa sitaki kwa mention pia, utaona ndio wanalipwa mshahara mkubwa na nyinyi mko hapa na this kind of knowledge. Nikuta mmerudi kutoka strike bila kulipwa. So kwa haya machache tuendeni chai ama niombe chai. Father, in the name of Jesus Christ, I want to thank you and bless your holy name for the far you brought us. We have a cup of tea and the accompaniments. As we partake of them, bless them. And it's in Jesus' name we pray and believe. Amen.
take your seats here so that we can have the Q&A session. All those who presented this morning, mkuja mtumeambia pia kama tunaweza have male involvement in what? In breast examination. There's somebody who presented on self-breast examination. Then we can have male involvement. Can we be involved? Tujue kama pia male involvement in self-breast examination. Can we be involved as men in doing the breast? If you are to teach men on doing breast examination at home, can we have better outcomes? That's another maybe we can have during our next conference. Someone to take up that challenge. Akuja to present here. By that time maybe atakuwa collect data to give male involvement or teaching men how to do breast examination at home for their spouses or partners. Can we have better outcomes? In fact, we have very many research questions here. Yesterday we had something from the VC on Equitable. I think we'll have a presentation next year. Very research problems identified. So thank you, the presenters. So we can go ahead and ask our questions. The mic is here. Somebody will assist me in giving a mic to those who have the questions. You don't have any other in asking questions. You just raise your hand and somebody is here. Okay. Actually, you have raised your hand.
Yeah.
It's still morning. It's still morning. Good morning, everyone. So this just I'm just concerned to someone this presenter he talked about banyan tree. Just a concern. Did you do a follow-up on the mother whether the osteomy and how is the mother doing with the baby?
Yes, good morning, everyone. My name is Lydia Mochiche from Vihiga County. My question goes to Cynthia Fabrice. It is about, the topic was about improving adolescents' uptake of family planning services. My question is, how do you deal with consent amongst the adolescents?
Good morning, everyone. Okay. So good morning once again. I think I also want to do a rejoinder for the age of consent. That was a very good topic, however much improving the adolescents and young friendly clinics. Our age of consent in Kenya still goes with 18 years, and we are having a lot of litigations. How did you take care of healthcare providers in regard to law-abiding country? Or maybe was there a recommendation to adjust that for your project to thrive for longer, now that we are also still existing in this country with the current constitution? That was for Cynthia. For Margaret, thank you. That was a very unique presentation. At some point, I thought termination of pregnancy would have come at first instance with a bullet on a hip joint. This mother cannot go into labor. I thank God we got a baby eventually. I don't know whether the mother had trauma even throughout the effect of the psychological part and the pain and the theater and the GA. Miracle must have happened for us to have safeguarded that pregnancy. So I think I just wanted to applaud the priority that was given to do the surgical management, and we still prevented the integrity of the pregnancy, and eventually we got a baby. So basically not a question, but to me what would have come first? The way we always say you can terminate pregnancy if the risk of pregnancy now outweighs the benefit. But that was a well done management, and even the follow-up for story, I think I'm also eager to know whether we have done a chronological follow-up on whether they needed maybe more follow-up.
Yes, and the other one was on tracking by Catherine Muthoni. I had a concern whether we got an intrauterine growth retardation from the examination they did. The further health was 34 weeks, but the maturity by date was 40 weeks. I know weight was not mentioned during the presentation. Did we get another weight or did we get a normal baby? And I know it is common, especially with PET, to get intrauterine growth retardation. Growth restriction, yes. So was that a confusion of the fetal height? What maybe was the baby a normal weight? Did the baby thrive also after? I think we followed up on the mother, even going to renal and going to the other dialysis, and we didn't get the feedback for the baby. And finally, yes, for Ben, I think I had written the question before you gave out your recommendation. So my recommendation, my question was actually on 28% of the institutional barrier was a significant barrier. But I think by the end, you answered my question that institutions should incorporate an environment where men should be incorporated in labor ward, if not in antenatal ward, and in postnatal ward. I know most of our institutions are not doing that. That is not only happening in Kitare, but I think it's a call for action for all our institutions. Thank you.
Good morning. I'm also interested with the presentation of parity, and I'm also concerned about the psychological part of it, how you took care of the family. Now that she had dropped her daughter in school and she has been shot and the other children waiting, and I'm imagining it's also her father in this family. How did you incorporate all of them in the process? Thank you.
Thank you so much for great speakers for the morning. We really appreciate the learnings that we've managed to get from your great presentations. So I just had a comment on the pregnancy-related acute kidney injury. Thanks for this presentation. A number of times in EMOC or in maternity, we do not go this deep to have these learnings. And it's something that we picked up from our moderator of this session. We'll really be engaging our renal nurses much in maternity, in EMOC, so that we get to understand the details. And just to highlight what are some of the preventive measures you would like to share with us, because this one we can be able to undertake during antenatal period or during labor management and postnatal management. Also a comment to Ben on the male partner birth. You brought it very clearly, and you say that there were traditional or cultural barriers. I don't know in your recommendations what were specific actions that you need to undertake to remove this bottleneck. However, it is a great study, and also in your recommendation, we will just looking up to involving male across board, from before pregnancy, preconception, during antenatal care. We usually have maternity open days. How do we also engage men during that time? And not only husbands, but also just calling them male partners, because now with the Gen Z, sometimes they are not husbands, but partners, and as such. And just walking the journey with them. I think that those are my comments. And also, I really appreciate the issue of infrastructural redesigning. Our labor wards are not well redesigned. And actually, moving forward, if we are reconstructing maternity units, we really need to come up with better designs. I love the current even Pumwani design where a mother is admitted and they labor where they are admitted and they deliver there. It's very, very good. And I know some facilities also have that. We're looking forward to that also in Kisumu. Thank you.
Any other question before we go to the answers? I think we are satisfied with the questions. Then we can have maybe Margaret starting with answering her questions.
Thank you so much, and thanks for the questions. Let me start with the issue of the psychological support. What I want to say is that at Moi Teaching and Referral Hospital, we have a full department of psychological counseling department. We also have the mental health department where we have even psychologists. Majority of the others are nurses who have trained in psychological counseling. So this mother was involved in psychological counseling sessions all the way from the time the mother came. Of course, the initial intervention was very life-threatening. That is the laparotomy. So after the laparotomy, when she was stable, she was taken through sessions, and at the same time, the husband was visiting. For us, what we do involve the patient plus the next of kin. That was the husband. And to say that initially the husband was very supportive to a point that he understood. Even when she was discharged, they were with the husband and the husband would bring her to them for visits. But unfortunately, I think it reached a point he couldn't take it anymore. So actually the husband left her. So she was left now with her pregnancy, her colostomy, and she had other 2 children. That is the one she had dropped to school, and then there was another one within the home. So what I would say in short is that psychological counseling was done. To a point it was very effective, but unfortunately the man later on left. To the follow-up, we were following her up as she was coming back for review by the gynecologist, and we could understand the way she's faring on. It was good. So lastly, let me allude to the issue of the first thought. When you see a pregnant woman with a bullet, with the pregnancy at 25 weeks, that would have been a first instance. But we are always encouraged, look at the whole patient and not necessarily the presenting problem. What do I mean is when she came, we had to do an ultrasound, and then we realized the baby was safe in the uterus. And this bullet was launched away from the uterus, away from the spinal cord, but at the hip. There's an entry point, but there's no exit. So it was confirmed by X-ray that the bullet was there. Maybe to finish off is to say that we have not removed that bullet to today. Because when she went home, she's doing her daily chores. Unfortunately, she's among the ones who are not learned because she actually works house help. She works for another family. So up to today, we haven't. She comes for review because it will depend on acceptance for it to be removed. But the last discussion I had with her, she was telling me, sister, it's not affecting me anything, but when it is cold, I feel like I'm feeling cold. But I'm worried, if I go for this operation, now this man ran away, who will take care of my children? So that is where we are, but we hope as we continue engaging her, then we can reach at a point of agreeing what is the best way forward. I hope I've answered the concerns. And thank you so much.
Thank you very much for your question about Praki. I didn't focus so much on the child because the neonatal outcome was good. The baby after CS was safe, healthy. I cannot quite tell about the birth weight because I do not work in neonatal ward. And the primary focus was to remove the mother out of danger. As long as the child was okay, and we wanted her to have a small process after delivery. But to notice that the child was well after the immediate CS that was done, and also the intervention for the mother when he started dialysis, and she was able to start even breastfeeding and continue bonding with the child. About prevention of Praki. Praki goes a long way from the community level. We have CHPs in the house, in our communities. So after they have noted a woman is pregnant and they have taken the vitals, what is the referral form? How do they tell the mother with a high BP where to go? You come back to the same level 1 facility, the nurse who's there, are they equipped to know how to handle hypertension in pregnancy? Because one of the challenges that we have is from the community level, the nurse is unable to refer properly or to monitor the mother because the skill or the knowledge is not incorporated in that level. So it would be important for the county nurses also, even when you're doing your monthly meetings, to sensitize the other nurses who do not work in referral hospitals about hypertension in pregnancy, how to manage hypertension in pregnancy, when to call for help, because we also should look at a way of decentralizing care back to the community as we go up. A mother can be hypertensive but asymptomatic, so there's no need to come to a higher level because of logistics, transport and everything included. But they can be managed on the lower level with advice, and then if there's need, we can refer them to the referral centers. The other way of preventing Praki is through education. If the nurses in MCH and maternity are aware of what hypertension, PET, PPH, sepsis, hyperemesis gravidanum does to a woman, when they educate the woman, now they are ready even to face the challenges, and also can liaise with the renal nurses or the other IMED department so that the care can be continuous and it's not one-sided. Post-delivery is very important. Our mothers are coming back with complications of Praki or with complication of PET. 3 months later, the mothers also develop heart failure because of mismanagement. When the mother has a safe delivery and they are home, that's not the end of the story about monitoring. It is good to align them maybe to a renal clinic so that they can be on follow-up to prevent AKI from progressing to CKD. Thank you for that question.
Okay, thank you for the questions also. Mine was on consent. My age group was 15 to 19 years. So the above 18, they give consent themselves, the 18 and 19 years. And then 15 to 17, mostly they come with a parent. The training was done to nurses in MCH and CHAS, community health assistants. So the community health assistants during the monthly meetings and barazas, even in a company of nurses, we attend and educate parents and caregivers on family planning for the youths and the adolescents. So they accompany, mothers or caregiver accompany the below 18 to come and give consent for the family planning. And then also the postpartum family planning that we give, when the adolescent has come to deliver, she's escorted by the mother or the caregiver also. So the postpartum is given by the consent of the mother. Yeah.
That's interesting.
Thank you. Mine was on. Yeah. So mine was on the culture and on the infrastructure. Actually, it's a mindset thing because whereas we have facilities that are high volume in terms of deliveries, we have facilities that are not very high volume. You realize that in that labor ward, that day, you only have one mother. But because of the mindset, you cannot allow the partner to be present. Not because there are other mothers, but because policy, not as a policy, policy does not allow. You find that, in fact, the 34 that were present, most of them were present in the health centers, not in Kitale referral, but in the health center, where you find she's the only mother in that labor ward. So akikuja anambo ingieni tu mkalishe. So they just stay and they are there. So in terms of culture, we have these Gen Zs that have not tried. And that is why you realize the 18 to 25 are more present than the 46 and above, because they don't really understand the cultures a lot. And I think we are moving towards that, where they also don't even know what the culture says. When we had question on culture, most of them didn't understand anything. The 46 and above will tell us, no, but to them they didn't say, they say, we don't know anything about the culture. So we are getting into a place where the culture is slowly being overridden by the education and also by the age group that is coming up. The reason why we didn't say partners is because we wanted to find it in the settings. We also realize and also appreciate unofficially that even the ones that our wives are giving back are not ours, but we are the husbands. We are just saying. So whether the baby is yours or not, but you are the husband. So support your wife kwa mission yake, amalize mission. So we didn't want to go the partner way, and we did not include people who are not married. So if you are not married, then you are not included in our study. We also realized that there's a lot of male involvement during antenatal. I think it goes up to over 90% of men get involved in antenatal. But when it comes to postnatal, intrapartum, the men are set aside. The other thing that I would want to say in regard to, this is speaking as a man, not as a researcher, that when you call us to that clinic, please make sure we have something to do. Because one of the things is, unasema, tulete mama clinic, tukikuja hapo, the only work we can do is carrying handbag ya mama. Na sisi wengine, kule tumetoka, you don't touch those things. So now we just get lost. So it becomes a woman affair. When we come there, can we also get some checkups? Can we get something? Can we receive some service in that stage? Ni hata pressure peke yake. Unashikilia mama bag, huyo anapima pressure, enda pale. What about my pressure? Hii pregnancy unajua inaweza nipandishia pressure pia. So let us also get something that men do. Otherwise they will not be coming. Yeah. And when we say involvement, let them not be wasikae hapa wakiona mtoto akitoka. Tunaweza lose appetite. But wacha tukae huku mbele kwa kichwa, tukimsupport, tukimpanguza sweat, tukimwambia babes we are doing this. Let us encourage us to tupeleke huku mbele. Na mtoto akitolewa nipatie mtoto wangu, nifanye DNA first. Thank you.
Sorry, allow me to speak when I'm seated. I did not have a question initially, but then as you were answering that question, there's some question that came to mind. I was thinking in terms of privacy, maybe allowing in the male partners. There's a time I was rotating in Pumwani maternity when I was doing my midwifery. Then of course in that scenario, I tend to think that there's some exposure because like you said, it is not only your wife who is laboring in this situation, and of course when women are laboring, especially when they are nearing second stage, you observe some behaviors. You'll see a woman who is walking naked, stark naked. She's in so much pain. One is crawling on the floor. I had a young midwife telling the lady, "Hey, mom, you're walking like a Nebuchadnezzar." She was walking on 4 legs. So in such a scenario, she was stark naked. So in case of such a scenario, you see the male involvement here. Some privacy is called for. Thank you. I just wanted to speak to that, and I don't know what your comment is on that. Maybe if you like to speak to that. Thank you.
Allow me also to say something, maybe to just comment on something. My name is Benjamin. I'm just concerned about the consent. When you're involving the parents, me as a parent, or all of us, how do we feel giving a consent to your 15-year-old girl maybe to make use the family planning methods. So hawa wazazi walikuwa wanasikiaje wakati wanataka kupeana consent to their other age children? Kindly give us a scenario how they responded to that.
Thank you. On the issue of laboring, nowadays we have respectful maternity care, and we are saying every woman, even we are all women, but I don't want to see your nini 1% or your mrima. I don't want to show everyone everything that I have, even if we are all women. So even if we are laboring in that labor ward, it's not supposed to be. I know the structures don't really allow, but every woman should have that privacy to labor in private, akiwa yeye peke yake. Si wewe mama panda kwa hii na wewe panda kwa hii na wewe panda kwa hii na wewe una move kwa hii. Next. So the privacy component. What we are saying actually is that it may not be feasible everywhere, every time, but it will be feasible if we have that in mind. It will be feasible some places, sometimes, where, for example, even in Chuka General here, in labor ward, unaweza pata hiyo siku mwenye anazaa ni peke yake. So the only people there are the nurses. We can, and I think the labor care guide allows for a companion during labor. And what we are saying, this companion should not be the sister. It should be the partner in crime. So let's have that in mind, that we have to assess, of course, for feasibility. There are places where, hata in that labor ward, kuna mahali inaweza fika umwambie sasa toka kidogo, then we'll call it because of the situations, right? So that is the subjectivity of male involvement during that. So let it be feasible. If we're able to do it in the places where it's feasible, then it can cascade to the government now providing for like Pumwani rooms where you just sit there, it is your place, you labor, you give birth there, and then everything happens there. Ukiwa peke yako. Yeah.
Thank you. Allow me to put just a rejoinder to Cynthia's work. And I just wanted to say the issue of consent, we should also be thinking about assent. And assent is whereby you have this underage, preferably from around 8 years to that 17 years, whereby you explain the procedure to this person who is underage, but of course there is the guardian who does the consent. So it is also good to think about assent, so that we are not just saying categorically that they are giving consent and maybe they are consenting for somebody who is much older, like even from 12 years above. So let us think about assent too. Thank you.
Okay, if I will give case scenario, of course, as a parent, she felt bad, like, let me say so. But she's told me, this was a grade 10, was supposed to be going to grade 10. She was 15, 16 years old there. She was brought by the mother, and I happened to be the one she found there. So as a service provider, hata mimi kwanza nilikuwa like, unataka kwanza why do you want family planning as a 16-year-old? But then I remembered the training ilikuwa don't offer the service. Usianze kukua wewe pia unataka kwanza kumcancel. Yeah. So me, I just listened to the mother, and the mother was like, sister, nisipompea ataleta mimba because anazunguka huku na huku anazunguka sana. So I made the hearing in play to prevent pregnancy, but I also talked about the condoms and everything about there. So she agreed to consent to prevent. She was a bit 50-50, but she chose to give the consent.
The same about the consent. What about when you are dealing with those minors, like some of us who come from communities where at 16, some are even mothers, but legally they are their wives, though they are under 18. I think that's where you talk of now the emancipated minors who can give their own consent. That's okay. Then on the issue of male involvement, we talked about that in my workplace, and we realized male involvement does not even include, it doesn't have to include that mother being in labor ward. Like them, we can just have a place where the men can sit within the hospital, because like we used to have challenge. We want like to take the mother for CS, and she tells you that the husband has to be contacted. In our areas, in pastor areas, most of the areas don't even have network that you can call the man to come to the hospital. So we agreed the men can just be hanging around the hospital. You have somewhere they can just sit. When you need to tell the man about the progress of the wife, you just tell him that we are going this way. The baby is okay. She'll be okay. If you have to go to theater, at least that is also male involvement. It doesn't mean that it must be in labor ward, because some situations it's hard to have. Like you're having 3 mothers in labor and getting 3 men there, I think the mothers will also be comfortable. So we can just find our own ways, local solutions of involving the partners. That's what we did in our area, and it is working. Thank you.
Yeah, in the spirit of male involvement, as you put it, I think we have been incorporating having men in our ANC, and we have the HIV testing, and we even encouraging even the VDRL testing for the men. So let them present themselves. The package is available. But again, when it comes to labor and delivery, maybe this goes to the institution. The moment they deliver the woman in labor into the maybe first stage or second stage, they get forgotten. We have seen that when we actually even acting in drills. The husband came, brought the wife, and immediately they become persona non grata. You forget about them. So institutions should be able to take care of them, update them regularly, and also feed them. Let them not go out looking for food. They'll eat and drink and go astray. So the institution should be able to habitate them within the institution, give them immediate feedback, tell them don't go away, we are still coming back after 30 minutes, so that they can also feel they are significant in the whole process. Yeah, for the emancipated minor, that one is covered by the constitution, that one you don't have to struggle with it. Those ones you can freely, as long as they're coming for CWC, for postnatal care, those ones there are no legal abiding consequences. But I think issues of consent, we have even gone to court, having offered family planning to these people who cannot actually consent without an ID. But that was well done. I know our 2 presenters there were not asked questions, especially for the self-breast examination. Our moderator mentioned during the tea break, how about involving men to conduct self-breast examination for the year, to conduct the breast examination for the year wife? Did that come to your mind? How did you involve men to be part and parcel of encouraging the year women to do self-breast examination? They should actually be the one to detect. They should be the first people to detect anomalies in the breast and anomalies in the cervix. So let's involve our spouses, our men, to be the one actually introducing or even promoting self-breast examination and issues to do with the cervical cancer screening. Yes, and about family-centered care, I know, especially when it comes to comprehensive neonatal care, especially for babies who are in LBU where we keep the parents away, FCC comes along. So that was a good presentation as well, and I think it's still opening many avenues for research. Thank you.
Maybe we can have someone leading us with appreciating our presenters. They have done a good job. So someone to, okay, yes. A question?
Not a question as such. Good morning. About the concept, I wanted to add something there because my colleague at work and such a case of consent giving, and even she was taken to the police post because of giving family planning to under 18. Most important is to document. Make sure even after the consent is given, document, and even the one giving the consent on behalf of this under 18 signs. Hiyo ndio ilimuokolea. Sijui mambo ilifika aje kwa politician, ikawa sasa amepelekwa pale, ameitwa post. Ilibidi atumane achukuliwe family planning register, ikaendewa. The good thing ni hiyo documentation. Na hata kwa mother child handbook alikuwa amedocument that the mother has given the consent. Hiyo ndio ilimuokolea kesi haikuenda mbele ikiishia hapo. So it is important. Hata tunaambia kwa kila wakati, make sure after doing it, you document. So if you have not documented, it is not. You cannot start convincing people that there was consent, yet it is not documented. Thank you.
Any other input before we appreciate them?
Good morning. Mine isn't a question, it's an input, a general input. Thank you to all the delegates. I think one thing that encapsulates all that we have been talking about is FCC. Yeah, in everything that we have covered, I think generally what you can say, FCC is important. During antenatal, male involvement, intrapartum, postnatal, and even in the neonatology units. I think there was a research done in the US about FCC and the outcomes of neonates, preterm neonates, when we incorporate both the mother and the dad. Yeah, so generally that's it. And another recommendation to all of us, we should focus on family history and physical examination during the MCH. I think one of the presentations yesterday was about incorporating it into wellness clinics. Sindio? Yeah, so from the Praki, we do not do our histories appropriately, and we do not do physical exams appropriately at the MCH. So to all of us, that is a recommendation to our MCH nurses. Thank you.
Thank you for the input. I think we have had a very good session. We've learned a lot, and I hope Prof is not in. I think because from the presentation we've had, the level of education is associated with many factors, adverse outcomes. What if we were to incorporate maybe reproductive health as a unit in the university, as a common unit? Because most of the universities have maybe HIV as a common unit. What if like issues of reproductive health can be incorporated as a common unit? So you know the common units in universities, like most of the university have things like ICT and HIV AIDS as a common units. What if we were to have that as a call for action? Getting and H issues maybe being incorporated as common units. We'll share that with Prof. I think she has stepped out, so that I think it's something that can start with Chuka University, which is a holistic university, the prophetic university. Maybe it can start, then the others will follow. So Dorothy in? She leads us with appreciating our presenters. I'm another idea. Kate from Machakos, help us present in appreciating the presenters kindly. The way you do it in Masako. Can you just step forward? You help us appreciating their good work.
Wengine hatujui ni huku juu sana.
Wewe panda pale.
Sawa.
Good morning. Huyu ndio Kate from Machakos. Awashira anapenda kunisumbua. Apologies, Team Machakos has missed most of the morning session. We had a car breakdown, but we are well. We are here now. We have missed things that I've heard we really wanted to hear. But it is well. We will catch up. Sasa, you have done a great job. And you are the change we need. So this team is going to appreciate you. And because you're mixed, I can see yellow, blue. A gentleman is representing very well in a nice coat. Mko tu sawa, mko very beautiful. Sindio? So we are going to make them a bouquet. Sawa sawa. So I want flowers of all kinds. First, let's weave our basket. So we are going to weave our basket. Everybody weave your basket. Make sure it's well rounded. Make sure it's well rounded. You have your basket. Kuna watu watengenezi basket. If you're not making, you're going to make it alone. Alright, now our basket is okay. Let's get from yellow flowers from Cumberland. That's how we roll. And it's like Margaret belongs to us. Let's pluck. Please place them well. Make sure that your arrangement is professional. Alright, let's get some reds. Which side do we get the reds from? Masai. In the Washira. Okay, let's get some reds from the Washira side. Good. Arrange them just next to the yellows. Alright. Then next we are going to have some greens. From where? Chuka Meru. Chuka and Meru. Tembea huko, get some greens. Okay, they are just next to the reds. Thank you. Then now we are going to get some pinks. From where? Laikipia. Alright, let's go to Laikipia. Tuna travel haraka. The pinks are just next to the greens, right? Then now where are we going? No, the white is the last. Where are we going? Kisumu, what a color are you giving us? Some purples. Nice, get some nice lilacs. Some nice lilacs. Good. Place them just somewhere next to the... No, let's come to the other side. They are not next to the pinks, they will clash. Let's place them on the other side. Thank you. A little bit of black. Who will give us black? We need just a touch of black. Kiambu. Aya, basi mtupe nyeusi. Kiambu mtupe nyeusi. Haraka Kiambu. Thank you. Watu watika, asanteni. Tumeziweka hapo. Si hizo kala zitoshe. Sasa, from all of us, let's get some nice whites. Nice whites. Very nice. Some roses. A little bit of that kalong one that is different. Place them nicely in the middle. Are they well in the middle? Now I want some dry grass. Which community will give us Nakuru? Some nice dry grass. I am basket what to pay dry grass. Mkono ubaya. Just a few grass. Kidogo tu. Place them strategically everywhere to give it a rustic look. Is that okay? Wow. Alright, let's get a few ribbons. Which color of ribbons do we want? Pink. We mix pink, white and purple. Right? Okay, let's take the pink ribbon. Tie it around your basket at the topmost part. Get your white. Let it come next. Then now do a purple just down there. Okay, carry your basket. Well, make sure your basket is precious. Deliver it to each of them. Thank you, we appreciate you.
Thank you, Kate, for pressuring our presenters. Tumesoma sana. And Prof, when we had stepped out, tumekusanyana kidogo. Tukasema, this being a prophetic university, and you know we have some common units that you normally teach your students. What if we were to come up with a curriculum to have RH issues being a common unit in the university, and maybe others will copy from this prophetic university?
Yeah.
Well, that's okay. Thank you. Wow. Okay, Keta anakuja kutuambia kitu kingine.
RH is our specialty, right? We can't give people it free, common like that. But we can have it restructured to something like family-centered, care. Just something very small, but our reach is wide and it belongs to us.
Umetupa mawazo mema. Tunashukuru from Masako. Najua Masako tunasemanga is the place to be. And you've never visited Machakos, haujajua mahali Kenya. So one of these days tutapeleka conference Masako, si ndio? From there twende wapi? Kisumu City. So we've had a good time. Kisumu da. Na baadaye lazima tuwekewe wimbo moja ya walisema wanataka rumba kutoka Kisumu, walikuwa wanasema hivyo. Hiyo lazima tutakuja hapa to dance as we celebrate. So thank you presenters, you can take your seats. Asante sana for the good upstart and being our inaugural AGA, the National Scientific Conference. You have really done a good job. So I would like to welcome one of our officials here of the association to say a word, who is our secretary, Lydia. Yes. Oh, okay, sorry. Oh, there was a partner who had supported us. Before she speaks, we can have the partner who supported us aongee kwanza, ndio tubaki tukiongea mambo ya nyumbani. Prof amesema pia lazima watu wa dance. Ataweka mugithi, yeye atasikiza mugithi. Human body is a living body. Ile inakuja. Let the music move your body. Ni mbaya kweli. So, as wait for the so, thank you. So tumesikia walitusupport na hii maji yote tunakunywa. So we'll be doing injustice to them if we are not to give them even 5 minutes of our time, at least to see what the services they offer to the public. Maybe pia nyinyi sisi tunaweza ona kuna kitu tunaweza benefit from them. So let them come and share. And even in our places of work, if you have any partners, next time during the conference, umeongea nao, tupata wengine hata from Makueni wakasupport the reflectors. Uliona ni vile tu hakufika hapa, the reflectors came from a partner from Makueni. So yeah, the reflectors came from Makueni. So hata wewe kama uko na any partner you're working with in your county, in your workplace, mwambie next year tukiwa Mombasa akuje. Southern Star, we are very much appreciative of the good partnership we are having with you, and we would like to welcome you on stage so that you can share with us what you normally offer to the public. Karibuni.
Good afternoon. For Salama, we are staff from Southern Star. We are very humble to be here and so happy. So leo tuliwaletea mazuri na jana pia tulikuwa hapa. We have some of our members here. Na kama wenye join, unaweza pia kujoin. To join process is very easy. We just hapo tuko na form, unatupitia hapo. Tunajaza form, tunafungua account. Ukifungua account ukiregister na sisi, you can access our services through M-Sacco. Kwa na simu yako mahali popote huko. Tuko na branches all over. Pia unaweza visit our branches. Na pia kwa watu wenye wako na biashara, pia tunapeananga pesa mzuri sana. So pia you can access our loans even through your phones up to 50,000. So kama you are not a part of our member, you can also join us. Na kuja hapo tunafungua account within 1 month, 2 months, unaweza access pesa. Much welcome. Thank you.
Okay. Good afternoon. I am Dennis Mochombo, and I work in Southern Star Sacco. Place where we say a better life. That is what you get to enjoy when you are actually a member of Southern Star Sacco. Let me say, to begin with, my friend Brian. He is called Brian. He hasn't said his name, but he is called Brian. Let me say that joining us, you just need to have a copy of your ID. You can have it as a physical ID or even a soft copy. That is the first requirement. We have to identify who you are. Then you just start with 300 Kenya shilling. With your 300 Kenya shilling, you are able to register. Registration fee is 200 Kenya shilling and at least a share to begin to be a member. That is just being a member. But to be a full member so that you can be able to actually qualify for the services, that is the credit facility. For you to qualify for credit facility, you have to get a share capital. Our minimum share capital requirement is 10,000 for those who are actually accessing the credit facility. After having the share capital, you need to have a super safe deposit. On the side of the super safe deposit, that is which we usually multiply by 4 wherever you need a credit facility. So you can get a maximum of up to 500 Kenya shilling by your own. However, if you need anything above 500 Kenya shilling, actually you have to provide for, that is something like a collateral. That is 500,000, sorry. Yeah, 500,000, sorry. Up to 500,000. That is what, that is why we are working as a team so far, to be collected, where we are making some errors here. So it's up to 500,000, whereby you have to be by your own. But if you have to acquire any credit facility above that, you have to provide for either collateral. And what you actually want to acquire can become a collateral. So let's say you need a car, you need a farm, like a shamba, Kama unahitaji kashamba mahali, ama unahitaji kudevelop a farm that you have. Just provide the title deed or even the logbook, and you are able actually to acquire something that is of a value up to 80% of the same year. So at Southern Star, you are getting such services. Okay, to get the home bank, that is that piggy bank that we have actually at our table out there. You actually need to register with a minimum balance requirement of that account. That is the Smart Junior when you are na watoto wadogo. So to acquire that, you need to register, and then to register for it, you need your copy of ID or one guardian copy of ID or identification, and then either a copy of birth certificate or a copy of notification certificate. Yenye unatokanga nayo pale hospitali ama yenye unaendea pale Huduma Center. So those are the requirements for you to actually open a Smart Junior account. Let's say on the other side now of the Christmas, if you are planning for your holiday, Christmas holiday, we have a Christmas holiday account. That one you just open with the Kenya shillings deal. Is a normal account, but you only transact beginning the first deck to that first deck at normal charges. Otherwise, when you happen to transact in that account, you can actually do your withdrawal, but it will have to charge you about 500 Kenya shilling. Yeah. So it is actually wise to transact with that account if you're actually planning for the December holiday. The other account is a ordinary account saving. Hiyo yenye sasa ndio iko na share capital, yenye iko na hiyo maneno na kupata loan hapa na pale, biashara yako, maziwa yako, kama kuna wenye wako wakulima bado. I know you have a side hustle, yeah? If you are doing something else somewhere, you can actually have an account that is actually transacting your business out there. And the other side of the salary, we usually give a salary advance that usually takes up to 9-month repayment. However, you can negotiate depending on your interest. Did you ukiangalia watu wa millions of money, It is negotiable period and at a very interesting rate. Yani iko very affordable. 16% reducing balance. 16% reducing balance, it means, let's say I state to you a credit facility of about 100,000. What I expect by the end of 1 year is about 108,000. Kuelekea hapo. Haitapita 10. Haitapita 110. Yeah? So it is 16% reducing per their credit facility. Now I think we are the best within the, let me say globally, we are the best. Because we are actually extending to you a very affordable credit facility. So for you to be able to acquire our services, you have to actually onboard, first of all, as a member with a registration of minimum 300 Kenya shilling. You have to actually input slowly by slowly your share deposit. When you have your share capital there at 10,000, any other super safe deposit, it is actually multiplied by 4. Amesema maneno na the 50,000 njikwamue ile ambayo unaweza kupata pale kwa simu. How do you get it? To be able to actually acquire the credit via your phone, *346#, you have to register with us for mobile banking. That is the M-Sacco services. For you to be able to register for M-Sacco services, you will need your ID. That is now later, or after you have saved for a while, and now maybe you are people from, I think you're from all over the Kenya. You are the delegate, the representative of different places. So don't be worried about actually transferring your money. We have got that facility for the M-Sacco, and you are able actually to access our services. And not just the 50,000 that you qualify for as a 70% of your super safe deposit. So for you to acquire that facility, you need actually to have the membership. That is the 10,000 share capital and a super safe. That means for you to qualify for around 50 calculations pale mbio unaweza pata labda itakuwa kitu super safe itakuwa kitu 70,000. So it is about you growing your super safe deposit, your share capital, and your account being very active for you to be able to acquire a loan. Actually for 3 months minimum. Your statement can be actually showing your capabilities. We have to analyze your strength for us actually to have the confidence with you that you will be able actually to pay back our loan. I would like to welcome any kind of question with regard to joining Southern Star Circle. And only that question, please. You're all satisfied? Yes. Okay, some of you are our members. We really appreciate that some of you have actually interacted with us out there, and they have actually added something to their super safe deposit and even the share capital. What I can say, as you get out, please, can you visit us at our table, and then we can be able to onboard you. Make sure you come out from here with something to celebrate, and we will never disappoint you. Welcome to Southern Star once again.
So, I just want to say something about Southern Star Circle and the relationship they have with us nurses, especially the School of Nursing and Public Health. In Chuka, we have like 10 banks, and we wrote letters to all of them. These are the people who responded. So can we appreciate them? We also had an annual scientific conference, the very first of it, as faculty-based annual scientific conference at Chuka University. That was by the School of Nursing and Public Health, and these people gave us 100,000. So they value nurses and they value empowerment. So whatever they are saying is true. Tunasemanga hao ndio wanajali maslahi ya watu wote, from the little to, and they even support private institutions, because I remember there is a time they supported my medical camp again with 50,000 shillings. So hawa ni marafiki wetu, si ni kweli? So tukue members wa Southern Star. Na wamesema they have M-banking, so you can withdraw money when you are in Kisumu Jane. Sawa sawa. Thank you very much. And therefore, munataka tuendelee na presentations 10. Tunamaliza. Unaona nilikuwa nataka work without play. Men who and I'm boy. Nilikuwa nataka sasa hii ni wakati wa kuburundika before lazima before nataka muongee msijani, nitaongea tu before tufunge. we have to shake our legs. We have to shake our bodies, because if you live here, you think that is how we live in Chuka University, that we don't like entertainment. We love entertainment. Mutasikia tu saa hii. And now I want to call upon Lindia has not talked, Patricia has not kidogo. So we can just take a few minutes and say something so that tuende kwa muziki, tupeane certificate, ndivi si akuje tupeane certificates, then we pray, tukule lunch. Bye.
Tunataka kudance. Ni dance tunangojea sahi. Hi delegates. How ni delegate itisha pesa. Sawa. Ikishindikana tuambie. Tutakuja huko na kina NNAK president tuulize what is not happening. Sawa. So let's feel encouraged. Tukue kwa decision. We want to thank you members for coming. We have learned. Sini sawa. Mimi sina mengi. Mine ni kusema tu twende tukafanye recruitment, tukue na members wengi sana wa rich. Si ndio? Mtu tu anasema ninaenda kuongeza 5. To recruit, tukue pamoja. Sawa. So tukienda nyumbani tuende vizuri. Thank you so much.
Mambo imechemka. Si imechemka sana? Imechemka ijachemka? Na munaangalia ni kama mmechoka. Unless you miss nani leo wamekosa chai? Tumekosa chai. Yeah, so my name is Lydia Mocheche, nursing officer from Vihiga County. Nimeuliza wenye wanakalia pesa, mimi sikali pesa. I'm the assistant director, deputy director nursing services. I know have students here. Mwingine jana alisema nilikuwa na wakalia sana. I know I'm tough, but I also have to make sure that the nursing standards ziko elevated to the best. Sindio? Nurses, sindio? Yes. Yeah, so currently I'm the secretary of the NNAK Reproductive Health chapter, and proud to be a midwife, specialized in midwifery. That is my area of specialty. So what I want to say is, as we go back to our counties, delegates, muko salama? Muko steady kweli? Yes. This is another baby mwenye tunataka kukuza. So what I can say is, as we go back, let us be ambassadors of our profession. In most circumstances, you find that nursing has been forgotten. Because we don't want to be in professional bodies, we don't want to be in these associations, so that at least we can push agendas that really touch the nurse at our counties. So tukienda tuambie our colleagues that let us mobilize them to ensure that we have registration increased from whatever that we are having right now. Like for the NNAK, let us ensure that tukue ambassadors wazuri. Tusikue wale wenye tunaenda tunakanyagia. Let us be ambassadors, because I know I have friends here wenye tumetembea na wao, and it is good that I see them in most of the conferences, because most of the people ask, what are we going to get from these conferences? I tell them one of the things that we get from the conferences is knowledge and sharing of experiences. Like what I've seen from this conference, I'm amazed. I didn't know that we have nurses who can do such kind of papers. Those papers were very powerful. Nimeangalia, nimesoma. For the first time sijalala hata kidogo. They were really challenging me. Nilikuwa najaribu hata kuangalia hata macho, hata uwezi, hata usingizi inatoka wapi. Yeah? Nani hajasoma? Si tumesoma sana. Those papers, and I really want to appreciate the presenters. That was a wonderful job. And for all of us, let us also be like motivated, so that we can do. Let us go get into a field of research. We are living in that is why from our theme you see that we are also having innovation, and you can't have innovation without research. Sindio? Innovation comes with the research. We have a lot of data, like whatever my colleague was from Viga was presenting here, though that is a data yenye wengine hawajui that it can take you places. You can present it somewhere, because tunatengeneza data but we leave it to other people. We don't know how to make use of our own data. So let us own our data, let us make use of it, share the experiences, share the knowledge, so that other people can also take back to their places of work, and also ensure that there is implementation. So from the conferences presentation, what I want to encourage all of us, I know the people, our delegates who did presentations here, they are so passionate from their areas of practice, because that is what came out clearly. So let us copy from them, learn the best practices, so as we go back, tusikuwa tunaenda kufanya vitu the way we have been doing them, sindio? Because nikienda, I want to do what Margaret said, I want to do what Kate said, and all other presenters. Maybe another thing that I want really to say is, let us be each brother's keepers. Sindio? Let us find out what is happening from other counties. Like the other day I was talking to Bungoma County. Si Bungoma wako hapo kweli? And it was a concern, because I was like, muko wapi? They told me that, tulikuwa hatujasikia that we are having a conference for the reproductive, the NNAK reproductive health chapter. I know there are counties when you're like Margaret here. I love her. Margaret, hi. Hi. Yeah, like MTRH. These are guys when you're zingine nikiona hawajakuja, will always call Margaret, mnakuja. You guys, are you coming? You know, these are guys we usually work with, and let us ensure that we check on our brothers and sisters to ensure that they are part of this big history, that's like what we have made for the past 2 days that we have been here. So as we go back, I would just want to say that as the secretary of the NNAK Reproductive Health Chapter, we are determined to work to ensure that this chapter is elevated to a very high level. We are not going to sleep. This is not the end. It is just a beginning. So msisidhani tunaenda kulala. Sasa ndio tumeanza kazi. Sindio? Tumeanza kazi. And I promise you next year's conference, we hosted some time back last year, but it was last year. We hosted for the Hexacon in Vihiga County. It was wonderful. Maybe next time we can also host the same in Vihiga County. Right, Prof? Yes, the uko mali tunasema kindiki. Yes, what is this? Hey, so we can also plan and also invite you to Vihiga County, so that at least you people can travel. And also but we don't have an airstrip, but our people from Kisumu tuko na airports, not airstrip. So you can just land in Kisumu then take a ride to Vihiga County. Otherwise, I want to say thank you so much for the delegates for being here. It was a wonderful 2 days experience. I've really enjoyed, and I'm very pleased to have you here, to see you guys here. And I pray as we move forward as the NNAK Reproductive Health Chapter, we are going to make it work. For other conferences that we are going to have, let us have the papers the way we had for this conference. Let us come in large numbers, let us support each other, and also let us ensure that we increase the membership. Thank you so much, na ninawapenda sana.
Sasa ni wakati wa rumba. Si tusimame. You know those seats, you can't do anything when you're there. Unaamka inakufuata. Kiwako wapi? Ama ni Mosa? Wapi? Mliacha nini? Tunataka hiyo wimbo. Wangari. Ikuje, itupate. Tuongee hiyo ya huko Mombasani. Wanasema wanataka kanuni. Hiyo ndio tunahitaji. You cannot stand your material. What is this?